model that we think about and that we've been using for over a decade now, which allows us to compartmentalize patients into various groups. As you can see on the left-hand end of the spectrum, patients with clinically localized disease who generally go for radical prostatectomy or radiation, some on active surveillance, obviously. And those who recur, generally the first manifestation is obviously a rising PSA. Many of those patients we observe, but in other cases we treat them with androgen deprivation therapy, which can eventually lead to a rise in PSA in the setting of a castrate testosterone. And for those patients, we really had very little in the way of effective options, and that's really where the two new studies that were presented at GU ASCO, Prosper and Spartan, come in. Until this year, there were no therapies approved in this disease state, and it's a challenging group of patients to take care of because you see their PSA rising. There aren't a lot of effective options. We use first-generation anti-androgens, drugs like ketoconazole, which have no proven survival benefit, and you're really just waiting for the metastases to eventually show up on the scans. We knew from work from Matt Smith's group that faster PSA doubling time, particularly those who had a doubling time less than 10 months versus greater than 10 months, did worse, and the faster the doubling time, the shorter the time to metastases. And so one drug to try and approach this problem is enzalutamide, which is approved for metastatic castration-resistant prostate cancer in both the post-docetaxel and pre-docetaxel setting based upon two pivotal phase 3 trials. Subsequent work in the STRIVE study, which included both non-metastatic and metastatic CRPC, compared to bicalutamide, showed that there was an improvement in radiographic progression-free survival and death, a composite endpoint, with enzalutamide versus bicalutamide. And again, there were about a third of these patients that were non-metastatic CRPC. So this provided the rationale to determine whether or not using enzalutamide earlier in a non-metastatic setting could be effective. So this is the study design for the Prosper study with enzalutamide versus placebo. It was a 2-to-1 randomization, enzalutamide versus placebo. The primary endpoint was metastasis-free survival, defined as the time to radiographic progression or death within 112 days of treatment discontinuation. There are a variety of secondary endpoints, including safety, overall survival, time to PSA progression, etc. This is a breakdown of the demographic characteristics for the patients, which were quite similar. Of note, the PSA doubling time, although the criteria just called for a PSA doubling time less than 10 months, the median PSA doubling time on this group of patients was actually quite rapid in the three-month range for both arms of the trial. This is a breakdown of the adverse events seen on the trial. There was a higher proportion of any adverse event with the enzalutamide-treated patients versus placebo. Part of this may be explained by the fact that enzalutamide-treated patients were on longer, so they had a greater time frame to develop an adverse event. And then when you look at grade 3 adverse events, higher in the enzalutamide group. This is a breakdown of individual adverse events greater than or equal to grade 3 occurring in greater than 1% of patients. And some of the usual suspects that we see in large phase 3 clinical trials are on this table here. And they appear very similar between the two groups, enzalutamide versus placebo. These are some of the adverse events of particular focus. Hypertension, higher in the enzalutamide versus placebo patients, whether there's a physiologic explanation for this or whether this is merely a function of patients being on drug longer and being able to be diagnosed with hypertension in greater proportion isn't entirely clear. There were several seizures in the enzalutamide-treated patients, 3, none in the placebo group. But this, again, was a very rare event, which goes along with the results from both the PREVAIL study and the STRIVE study. They also looked at progression events in the two groups, and there was about half the events in patients treated with enzalutamide versus placebo, suggesting that there was certainly greater tumor control or a prevention of progression with enzalutamide. What was interesting, I still don't have a good explanation for this, was the fact that there was an excess of deaths in patients who were treated with enzalutamide who discontinued study treatment within the first 112 days. And these are subjects without radiographic progression who are dying in excess numbers. And so I I struggle to find an explanation for that, and there weren't information shared at GU ASCO to really provide a basis for this. But it's something I think we'll have to keep an eye on. Are patients with enzalutamide, even though they're going off study without progression, are they having some infirmity that is really making them predisposed to death, or are these fractures, are these falls, are these cognitive changes that in the absence of disease progression are leading to death in these subjects? This is the MFS plots, the Kaplan-Meier curves. You can see there's a substantial difference in metastasis-free survival in patients treated with enzalutamide versus those treated with placebo. Almost a 2-year difference in metastasis-free survival between the two groups. This is a forest plot showing that really, irrespective of the variable they examined, there was a benefit favoring enzalutamide for metastasis-free survival, irrespective of doubling time, region of the clinical trial, performance status, et cetera, et cetera. And this is the overall survival results. At the time of reporting, the median overall survival had not been reached for either group. There was not a statistically significant improvement in survival, hazard ratio of 0.8 with a non-significant p-value. But again, we await more mature results. So I think in conclusion, it's clear that enzalutamide versus placebo improves metastasis-free survival, almost a 2-year improvement. The median overall survival was not reached, but it's not significant at this time. I think key questions that I think about, particularly as I see patients in clinic, are we really helping patients with asymptomatic CRPC, non-metastatic, by exposing them to enzalutamide or apalutamide earlier? I think this treatment is unlikely to be curative. I think eventually all patients will progress if they live long enough. There's no known survival benefit in this group of patients. There's no clear improvement in quality of life, and in fact, there appear to be an excess of deaths in patients who discontinue therapy within the first 112 days without progression. And we may be taking a very effective treatment option for metastatic CRPC off the table. So when these patients progress, what do we do for them? We have docetaxel, cabazitaxel, radium, which don't work all that well. And we're using up one of our most effective treatments for patients who really don't need a response because they're asymptomatic and have no metastatic measurable disease. And as pointed out by Larry, will this disease state even exist within the next year or two as we use more modern molecular imaging and we diagnose occult metastatic disease that is not detectable on a nuclear medicine scan or a CT scan? So I think these are questions that we'll have to grapple with. Certainly when we see patients in clinic, it's a very nuanced discussion. I've had many patients who elect to not want to take these drugs and to save it for if they develop metastases. So I'll stop there and happy to take any questions.
So do you think when generic Abby gets here that it'll just take over the space, or do you think the space is not really existent and it won't be something we talk about in 3 years?
I think there's no question that when Abby comes about, and this may be driven by insurers, even though there hasn't been a phase 3 trial in this space, that is the preferred treatment if you're going to treat a patient with non-metastatic CRPC. It'll be interesting to see sort of the race between Abby approval and molecular imaging, sort of which one takes hold first. But I do think that I find these patients are exceedingly rare. I have a lot of patients on androgen deprivation therapy for years. I stage them 6 months, every 12 months, and eventually you find metastases in these patients when they're progressing for the first time. So I think it is a small group. I think molecular imaging will make that group even smaller, and Abby probably will become the preferred option for these patients.
Think of the cost savings of $250 of Abby per day with food versus apalutamide or enzalutamide at full market cost. I mean, just think, we haven't done the study, obviously,
yeah.
but I mean, the cost is amazing here, and we really don't know how much we're benefiting people.
How patients are on ADT for protracted periods of time. The reality is it's a disease state that we created, right? I mean, there are a lot of people who are treated with ADT who never needed to be treated with ADT at all, who now progress. And I point out, we all know the label, we'll talk about apalutamide in a minute, and presumably the label will be the same. The label basically doesn't speak to PSA doubling time.
Right.
It just talks to castrate PSA disease, right? And then the last point is the definition for PSA doubling time used in these studies are a little different, but when you ask about it, it's actually just 3 rises of PSA with very low PSA values over at least 1 week apart. That's not the same definition that was used in Matt's study. So, I mean, in this whole concept of doubling time is, we talk about it a lot, but if you don't define what it is, it doesn't mean anything.
My perspective, apalutamide's a good drug, and we'll talk about it, but this clinical state, this unmet medical need was created to get apalutamide approved, right? And it did, and that's good, but it wasn't like we were all sitting around our clinic saying, gosh, if we only had something for these people without metastases, right? I mean, and it is a rare event. In my practice, it's almost all CRPC. It's maybe 5%.
So I have a quick question. We're all medical oncologists.
Well,
that this was created.
not all.
What do you think, Mike?
Point to the urologist.
That's what I'm saying. I'd like to hear, because I think that it's a different. I think that we think about these things differently, and they have people on ADT with their nurse practitioner clinics for how many years, and it's very algorithmic. Anyway, Mike, what do you think?
Well, I think this serves a purpose. I mean, it is true that we have a man-made created disease. We pigeonholed the drug approvals for metastatic, and this non-metastatic was an unmet need, so we sort of have 2 man-made artificial conditions. Having said that, and I have the next talk, but I mean, there is an advancement here, and there looks to be a significant delay in the development of these metastases if we don't have exact measurements for super sensitive scans. We have to believe those people are in this mix too, and at least based on conventional scans, we seem to be delaying some pretty significant bad outcomes. What's that?
What if survival doesn't reach?
Well, there are a lot of thoughtful discussions about these data and about whether or not treating patients is the right thing to do, but I haven't really heard anyone say that outside of the context of giving one of these drugs, they don't give anything. I mean, Josh, you just said that you give ketoconazole or something like that. So how many of us are just following these patients and not giving them something else? And if we are giving them something else, we might as well give them something that has data to support it.
But
Yeah,
it
I
also
think that's
depends.
my take.
It depends on the patient. I think that when we give patients androgen blockade, I think we're really underappreciating the general health effects that we're causing in our patients. The sarcopenia, the weight gain, the fatigue. Those are all really, really significant issues. And it's a very, very complex discussion with these patients, particularly if they have a rise in PSA and no metastatic disease to when to start androgen blockade. And then now you're putting another medication on top of this. Again, you're balancing off that role of metastases versus other secondary effects.
And let's not forget that the other disease state we also created is the use of bone-targeted agents, right? That was created because we started using ADT for prolonged periods of time and developed mostly non-clinical osteoporosis that we had to treat. So the larger issue is not what to do after they're castrate-resistant and rising. It's why do you treat patients with biochemical failure, the vast majority of whom probably don't develop disease, right?
And I think it'll be important to look at the overall survival results. If there is no difference, and later is as good as earlier, then I think that'll really speak to should we be using
Do
these
you
agents.
think we're going to see survival in these trials?
If there is not a difference, I think if there is a difference, then you have to ask, what was the access to these patients eventually?
Meaningfully, but for both of these trials, do you think we're going to, because of the way this trial was designed, do you actually think you're going to see survival?
I'd have to go back to the slide to see the number of non-U.S. sites, and that may drive whether or not the patients eventually had access to these agents
So
I'm
or not.
disappointed I won't be able to say live long and prosper.
Oh, for goodness sake.
Rob, one of the issues is this particular patient population had a median PSA DT of about 3.5 months. So this patient population,
but using
using a
whatever the
criteria.
doubling time was described, right? So they're not apples and apples, the doubling times.
But the real non-apple and apple is the real world, where the minority of patients fall into even this category.
So you think we're going to see survival data on this stuff?
I think it's a possibility we could see survival, because it really depends on the post-protocol treatments, right? And
Those curves are pretty tight going out to 4
they are.
years.
Yeah, they are, but that's because nobody
Post-protocol
does.
treatment, there's a lot of other therapy available in most of the places where this study was done. So it's not like it was 10 years ago.
I don't recall from Prevail, but certainly with the abiraterone in the metastatic setting, there is a clear difference in the early versus late in terms of not only do the people with less metastatic disease live longer, but they have a greater hazard ratio, a better hazard ratio. So it's possible. I just, just looking at this, that survival curve or that lack of separation is I think striking.
Well, virtually nobody dies of prostate cancer in the non-metastatic state for the first 4 years. I mean, I think those first 4 years are just a run-in, basically. So the real events are going to start to occur, and the 0.8 is not necessarily bad, but that still didn't get to my point. The real point is the vast majority of people, as you point out, and I agree completely, Ron, are put on ADT for probably inappropriate reasons, and now the disease state we created is now going to create another disease state that we created, and the overtreatment opportunities are almost endless.
I don't think there will be another registration study in the non-metastatic CRPC space. I think it's done. Yeah. One and done, or two and done.
Well,
there's one more.
Actually, there's one more.
Okay.
Darolutamide.
Now we're
Darolutamide. Yeah.
Okay. Yeah, we